Good morning. Thank you very much for this opportunity to present today. And I'll be talking about treating bloodstream infections, how long we should treat. And I'd like to acknowledge Dr. Rob Fowler and Dr. Nick Danneman for helping me with this presentation. And I also like to say that I have no conflicts of interest to declare. So the issue of antibiotic duration, that is how long we should treat infections for, is a very important question. Obviously, we don't want to treat for too short of a time because that could put patients at risk of clinical failure, relapse, and potentially select for resistant organisms. But we also don't want to treat for too long because then we could be increasing the risk for selecting for bystander flora, secondary infections like C. difficile, adverse events related to therapy, and increased costs in healthcare. So overall, excessive durations of treatment are the #1 contributor to unnecessary days of antibiotic use. Bloodstream infections in the ICU are common. A global point prevalence study has shown that it affects 15% of ICU patients. Bloodstream infections are also serious. They are associated with a 2 to 3-fold increased mortality. And while there's level 1 evidence that shortened treatment durations are effective in many different infectious syndromes like ventilator-associated pneumonia, cystitis, pyelonephritis, the duration of treatment in bacteremia, specifically in the critically ill population, is understudied. So why do we focus on treatment duration to reduce antibiotic overuse? Well, first, it's difficult to minimize the initiation of antibiotics. Diagnosis may not always be clear when we're starting therapy. Microbiology tests can be delayed, and we can also get false negative results. And there are cases where early adequate antibiotic coverage is strongly associated with survival. An example of this is Dr. Anand Kumar's paper from Critical Care Medicine in 2006, which studied the duration of hypotension before starting effective antimicrobial therapy as a critical determinant of survival in septic shock. In this study, Dr. Kumar showed that giving antibiotics within 1 hour of hypotension was associated with 80% survival in patients with septic shock. And furthermore, each 1 hour of delay of antibiotics decreased absolute survival by 8% in these patients. So early antibiotics can likely save lives, and we certainly would not want to prevent antibiotics from being started when they can be so crucial for patient survival. Another reason why we focus on treatment duration to reduce antibiotic overuse is that it is easier to reduce the length of treatment courses because diagnoses become clearer with time. Microbiology results eventually do come back, and the clinical course of the patient becomes more evident as time passes. So opportunities do exist for us to revise our plans on antibiotic treatment duration more appropriately. And of course, we must not forget that treating infections for longer periods after the infection has been cleared can actually expose patients to unnecessary harms without additional benefit. So shorter durations of antibiotic therapy can be sufficient for infections. This has been shown in other infectious syndromes. In this JAMA article from 2003, Shastra and his team showed that in patients with ventilator-associated pneumonia, those who received 8 days of antibiotic therapy had survival that was no worse than those who got 15 days of therapy. Of note, this was a non-inferiority trial that was powered to allow up to a 10% non-inferiority margin in order to show these results. Another example of using shorter course antibiotic therapy is the STOP-IT trial. This was conducted in patients with complicated intra-abdominal infections. In this trial, patients were randomized either to the control group, who received a median of 8 days of antibiotics, or the experimental group, who received a median of 4 days. And they found no difference in their primary outcome, which was a composite of surgical site infection, recurrent abdominal infection, or death within 30 days. The study was powered to detect a 10% difference in complication rates, assuming that the rate of complications would be 30% in the control group. Currently, there is also a lot of interest in the biomarkers, use of biomarkers like procalcitonin to help guide decision-making about durations of antibiotic treatment. In the pro-rata trial here, this was a randomized controlled trial to establish whether predefined algorithms based on procalcitonin levels to guide the starting and stopping of antibiotics could help to reduce antibiotic use in the ICU without affecting patient outcomes. So here in the Kaplan-Meier figure here, we can see that the 60-day survival probability was not different between the two groups. Mortality at 60 days was 30% in the control group and 26% in the procalcitonin group. An interesting thing to note in this study is that the protocol adherence was only 47% in the group using the procalcitonin algorithms. And at 7 days, as you can see the arrow here, approximately 50% of the patients in the procalcitonin group were still receiving antibiotics. And so that does make us wonder that even if we use procalcitonin-based strategies to guide antibiotic use, there may still be longer than necessary treatment courses with antimicrobials. So the next slide here describes the BALANCE research program. BALANCE stands for bacteremia antibiotic length actually needed for clinical effectiveness. This research program is focused on studying treatment duration for bacteremia and has international collaboration with researchers from all around the world, including New Zealand, Australia, Israel, and Saudi Arabia. As part of the background work in BALANCE, a systematic review of the literature on the duration of antibiotic therapy for bacteremia has been performed. There were 24 trials included in the systematic review, which involved 7,695 patients. Clinical cure was similar between shorter and longer durations of therapy, showing that there is no benefit from excessive antibiotic durations. And when we look at only those bacteremic patients from these trials, as you can see from the forest plots here, there were no significant differences detected with respect to the rates of clinical cure nor with survival. A Canadian national practice survey about treatment duration in bloodstream infections in the critically ill population was also conducted amongst 172 infectious disease specialists and critical care specialists. In the results from the survey, you can see here, for each syndrome, no matter if we are considering whether it's a central catheter bloodstream infection or bacteremia from pneumonia, UTIs, intra-abdominal infections, or soft tissue infections, the most common recommendation for treatment duration was 14 days. But you can also see here that there are also peaks at 7 and 10 days being recommended as well. And when we break down the pathogens, the distribution of recommended treatment duration for central line bloodstream infections is similar regardless of what the pathogens are. In general, 14 days was still the most common recommendation, with clear peaks again at 7 and 10 days as well here. So BALANCE next conducted a multicenter retrospective observational study to look at the actual treatment durations used in the treatment of bloodstream infections in critically ill patients. This observational study was conducted in 14 ICUs across 6 Canadian provinces. And the most recent 1,202 consecutive bacteremic patients admitted to the ICUs were included in this study. In the chart here, you can see what the actual treatment durations used were for various infectious syndromes. But overall, the median duration was 14 days with an interquartile range between 9 and 17 days. So that was quite a large range in treatment duration that was being seen. So this background work in BALANCE identified gaps in the current evidence, extensive practice variation, and established equipoise for a randomized trial to compare shorter versus longer antibiotic treatment durations for bloodstream infections. This has led to the BALANCE randomized controlled trial, which is currently being conducted across a geographically and clinically diverse spectrum of ICUs in Canada, Australia, New Zealand, the US, Saudi Arabia, and Israel. And BALANCE is supported by grants from Canada, New Zealand, and Australia. So the primary research question in BALANCE RCT is, in hospitalized or critically ill patients with bloodstream infections, is shorter duration antibiotic treatment of 7 days non-inferior to longer duration treatment of 14 days with respect to 90-day mortality? The secondary questions are whether shorter duration treatment is non-inferior to longer duration in terms of hospital and ICU mortality, relapse bacteremia, ICU and hospital length of stay, duration of mechanical ventilation, and duration of vasopressor use. And also whether shorter duration treatment is superior in terms of antibiotic-free days, allergies and adverse events related to antibiotics, C. difficile infections, as well as infection or colonization with antibiotic-resistant organisms. There's also a biomarker sub-study in BALANCE. Here is some pilot data for procalcitonin levels drawn at day 0, 7, 10, and 14. In the majority of patients have procalcitonin levels higher than the usual threshold of 0.25 for stopping antibiotics at 7 days. So this also makes us wonder again, whether biomarker-based strategies may actually allow for longer than needed treatment durations. So there is emerging evidence to support shorter duration therapy for bloodstream infections. In a recent paper in 2019, Yahav and team reported a non-inferiority randomized controlled trial of 7 versus 14 days of antibiotic therapy in bacteremia caused by gram-negative organisms. The absolute risk difference in 90-day mortality was only 1% and not significant, but the patients in this study were not critically ill, and the focus was, as stated in the title, only on bacteremia caused by gram-negative organisms. So the bottom line is this: antibiotic resistance is increasing, but our antibiotic choices are decreasing. So reducing antibiotic pressure is a global goal for all of us. Early adequate empiric antibiotic treatment can save lives, and choosing the minimal effective treatment duration will help reduce pressures. So there's evidence to support investigation of shorter duration of treatment for serious infections. Most studies have a large and non-inferiority margin and are not conducted in ICU patients. So a large international RCT that addresses this very important gap in research will provide a new incremental evidence for adequate treatment duration in bloodstream infections in the critically ill population. And this concludes my presentation. Thank you very much for your attention and opportunity to speak with you today.